Good evening. So I'm going to talk tonight about cardiovascular disease in women. So matters of the heart in 2023. Are women the forgotten species? I definitely think so. And I'm going to share with you why I have come to this conclusion. So what I want to share is some very sobering female heart truths. So if you look at cardiovascular disease in Australian women, it is quite sad to know that cardiovascular disease accounts for almost 12% of the total burden of disease amongst Australian women. And while the hospitalization rates for cardiovascular disease may have fallen between 2006 and 2015, this hospitalization rate actually increased among younger women. 11 Australian women die each day from an MI, and heart disease is the single biggest killer of Australian women. The irony is that it kills 3 times as many women than breast cancer, yet we all seem to be so focused on breast cancer. So are we barking up the wrong tree? We know that the remaining lifetime risk for cardiovascular disease when you compare it to breast cancer in women is far greater. So if you take a woman at age 40, her risk of having any cardiovascular disease is 1 in 2, compared to a breast cancer risk of 1 in 8. If you look at a woman at 70 years of age, this is even more glaring. So while 1 in 2 women again are at risk of cardiovascular disease, 1 in 15 women are at breast cancer risk. So a far lower likelihood of having breast cancer. Yet there is so much emotion attached to breast cancer. It is really very, very surprising. So why do we have this glaring gender disparity? This is multifactorial. Cardiovascular disease in women has been historically understudied, underrecognized, underdiagnosed, undertreated, and underrepresented in clinical trials. And to close this gender gap, I think we need to better understand both sex and gender differences in cardiovascular disease. And the perception that women represent a low-risk population for cardiovascular disease definitely needs to be reconsidered. So how different are women from men? We definitely know that male brain is very differently wired to the female brain, but I think we're discovering more about the differences in female hearts versus men's heart. A woman's heart may look like a man's heart, and it's not just a smaller version of the male heart. There's a lot of differences. Looking at the risk factors for cardiovascular disease in women, even that is a very different kettle of fish. So while women still share the established risk factors that are common to both genders, such as age, smoking, hypertension, diabetes, chronic kidney disease, dyslipidemia, and family history of premature cardiovascular disease, there are many risk factors that are specific to women, such as being postmenopausal, any pregnancy-related complication, whether it be preeclampsia, gestational diabetes, or hypertension, having a hysterectomy, preterm delivery, younger women with polycystic ovarian syndrome, or those who have early menopause, women with depression and anxiety, chemotherapy, particularly that for breast cancer, and of course a whole raft of autoimmune diseases. So you can see that the burden of risk factors for women is far greater than for men. We not only have the risk factors that men have, but on top of that, we have a lot of female-specific risk factors. So I guess it's very important to remind ourselves as clinicians that should we not only be screening women for traditional risk factors, which unfortunately put a higher risk of having cardiovascular disease compared to their male counterparts for the same traditional risk factors such as diabetes, smoking, or obesity, the risk of having ischemic heart disease related to that risk factor in women is far greater than men, almost 1.5 times. But then women have on top of that, a greater risk conferred by the virtue of having autoimmune diseases like maybe lupus, gestational diabetes, which makes a woman 59% more likely to have a risk of an MI, hypertension in pregnancy, which adds a 3-fold risk, menopause, and depression. And we know that depression is a risk factor that's far more prevalent in women and doubles the risk of ischemic heart disease. So this illustration really is kind of putting out there how many risk factors women are exposed to. And in addition to all the traditional factors, you can see that social determinants of health, such as race, ethnicity, socioeconomic status, also have a very strong bearing on that risk. Of course, then we cannot underscore the importance of the psychological risk factors that women are subjected to. And all of these factors what they share in common is that they drive the inflammation in the body, which is then in turn leading to endothelial dysfunction, subclinical atherosclerosis, autonomic dysfunction, and immune dysfunction, all of which then translate into cardiovascular disease, whether it be a myocardial infarction, heart failure, stroke, or sudden cardiac death. So I think just an awareness amongst clinicians that the woman sitting in front of them could be having one or more of the factors is making her a sitting duck for ischemic heart disease in the near future. And therefore addressing these proactively and urgently is a really big responsibility that we female practitioners, should be aware of. So I think the other problem that confounds women getting attention in time is the fact that women experience different symptoms. So while men experience the classic chest pain or shortness of breath, nausea with their MIs, women will experience very non-specific symptoms in the way of back pain, neck pain, jaw pain, or just vague tightness, heartburn, which is often dismissed as being reflux, or just vomiting, nausea, fatigue, which could be passed off as a viral illness. Women are more likely to have the right coronary artery occluded, which perhaps explains some of these differences, versus the left anterior descending, which is a commoner presenting symptom in men with STEMIs. In addition to that, women have far more subtle ECG changes even with an anterior STEMI. So there's therefore many pitfalls in picking up these women in a timely fashion. But then most of all, I think there are not only patient factors where women tend to be dismissive of their symptoms and are always putting other people's health first in the family before seeking medical attention for their own symptoms. Even though it was only 30% of women who sought medical care for an MI before hospitalization, out of that 30%, only 53% of these women actually were told that their symptoms were not heart related. And so therefore half of these women were missed as having cardiac presentations, compared to only 37% of men who were told that their symptoms were non-cardiac. So you can see there's a very clear bias amongst the treating clinicians in dismissing women's symptoms as being non-cardiac when they were actually cardiac. This resulted always in women having a much longer symptom to door time compared to men, which obviously then translated to poorer outcomes. Then once even women were recognized as being a cardiac patient, it took 25 minutes longer to open a blocked coronary artery in a woman compared to in a man. And that meant there was a longer door to balloon time for this woman. And all of this obviously then results in poorer outcomes for women. And these are figures from our own local statistics in New South Wales that were compiled by Associate Professor Sarah Zaman. And then, of course, then we have a raft of other gender differences. So only recently have we recognized that there are some very female predominant conditions that exist in cardiovascular disease in women. These being mainly what we refer to as MINOCA, which stands for myocardial infarction with a non-obstructive coronary artery. And this is how women who present with chest pain again are dismissed as having either musculoskeletal pain or non-cardiac pain, when this is a very serious condition. Then there is also the entity of spontaneous coronary artery dissection, which is perhaps one of the commonest causes of an MI in pregnancy, hence not an insignificant condition and very serious if missed. Women are more likely to have coronary vasospasm compared to male counterparts. And then, of course, there is that well-known entity called Takotsubo syndrome, which is colloquially referred to as the broken heart syndrome. And typically this presents in women who have gone through overwhelming stress in their life, present to their doctors with chest pain, which is again dismissed as being stress-related chest pain when it's actually a cardiomyopathy, which is very serious in these women and needs to be treated very urgently, because these women are also at a very high risk of sudden cardiac death should they not get the proper treatment that they deserve. So we can see now with all that I've just presented that there seems to be a doctor bias when it comes to diagnosing women with cardiovascular disease and getting them to access the correct treatment in a timely fashion. This has been referred to by some authors as what's called the Yentl syndrome, based on the famous book, which is about a Jewish woman having to dress up like a man just to be taken seriously in the Jewish community and be able to get to read the Talmud. And this phenomenon exists very much in our medical sphere, where women get attention only when they look like men. with a male pattern of obstructive coronary artery disease presentation. Sadly, the Yentl syndrome is evident even in Australia. As late as 2018, a paper showing that women admitted with an acute coronary syndrome, particularly the ST elevation MI, are less likely to receive invasive management in the way of stenting, revascularization, and preventive medications such as beta blockers and statins on discharge than men. Hence, women admitted to Australian hospitals with serious heart attacks were half as likely as men to get proper treatment and to die at twice the rate of men 6 months post-discharge, which I think is a very sad commentary on the state of health for women in Australia. So looking at this gender bias, then should we be choosing a female doctor if we want to survive? Sadly, the answer is yes. Gender concordance has shown to increase a patient's probability of survival. And ironically, women are more likely to survive a heart attack if treated by a female doctor. This in itself underscores the need to update the training that male physicians receive to ensure that heart disease is not simply cast as a male condition and there are no unnecessary deaths from this kind of careless attitude exhibited. The thing to realize and remember is that it's not a disease only of older women. Young women are not immune, because you can see that the continuum of cardiovascular risk in women starts from a young age, right from the time when a woman or a girl can have polycystic ovarian syndrome to then go on to insulin resistance. In pregnancy, all the complications of pregnancy that we've referred to, such as preeclampsia, having a miscarriage, having multiple, gestations, high parity, preterm birth, and the list goes on. Any of these pregnancy-related adverse outcomes confer a risk of increased cardiovascular disease for as long as 48 years after the pregnancy. So you can see that pregnancy is a pretty significant moment in a woman's life where she is at increased risk of cardiovascular disease. In a way, you can think of pregnancy as nature's stress test, where the high volume of blood flow can subject that heart to great strain. And while most women do manage to weather that increased strain, some women end up with adverse cardiac outcomes. And of course, as women get older, then they have the traditional risk factors of dyslipidemia, hypertension, obesity, and then comes their attendant sort of medical conditions such as a cerebral vascular event or established coronary vascular disease. So you can see that at every stage there's an opportunity to address risk factors and modify them and treat them. And if we don't, it is definitely a missed opportunity for assessing cardiovascular risk. So how do we shift this needle for women's heart health? I think we need to firstly recognize that there is a continuum of cardiovascular risk in every woman. So start young, even with your young teenagers, then through their pregnant mums, postnatal period, and thereafter monitor them. Especially women who've had premature menopause are at very high risk of cardiovascular disease. So follow these women very carefully. But for every female, I think we not only need to be looking out for these risk factors, but we should be doing routinely the numbers check their cholesterol, check their blood pressure, check their other risk factors, their weight, and try and counsel them about preventive activities, because time is muscle. And every missed opportunity translates into a very adverse outcome for that woman. Hence, I would say prevention starts in the womb, and there are opportunities, multiple opportunities along the way for addressing cardiovascular risk factors during pregnancy and beyond. So how can women in medicine correct this gender bias? I think in many ways. We need to create increased awareness amongst the patients in the community. We probably need to start looking at implementing sex and gender specific care and realizing that women are unique in some of their risk factors. They need a different approach and they need to be monitored closely. Perhaps we should even look at having cardiovascular prevention guidelines that are specifically implemented for women in primary care and under the care of the obstetrician gynecologist. And perhaps a greater collaboration between the cardiologist colleagues and primary care and all the other, disciplines that look after women. So basically, we're talking about a cardiovascular team that looks after these vulnerable women. But then, of course, we need to also consider having very culturally appropriate education, living in a multicultural society as Australia, and provide, the appropriate physician training and education to be able to deliver that kind of care. But most of all, I think we need to have improved advocacy so that we can have greater funding to address some of these inequalities. I think we need to realize that women's hearts are special, and cardiovascular disease in women is a now problem. Later may be too late. We need to move away from this bikini approach of only focusing on breast and gynae cancers and think about the number one killer in women, which is cardiovascular disease. So essentially, I think we can do better. We must do better because for women, healthcare needs to be more than this bikini medicine. So I think all of this makes me feel that there's definitely now a time for a Me Too movement in cardiovascular disease. And this has been echoed by some of the very inspiring leading women in the world. Melinda Gates has always maintained that empowering women changes the world. Barbara Streisand set up a Women's Heart Alliance with the businessman Ron Perelman in 2014 and has been responsible for funding large hospital kind of wings for cardiovascular health for women. And then our very own Associate Professor Sarah Zaman from Sydney has been a great champion for women in cardiology and to improve the women's outcomes with cardiovascular disease. And she always is reiterating the fact that the gender gap in cardiology is hurting all women, not just cardiology women trainees. Fortunately, now there are some campaigns for heart health in women that are being thrown all over the world. In Australia, we have her Heart campaign, which is trying to make the invisible disease in women, which is the biggest killer, more visible, and is trying to encourage people that we need to be focusing on women's heart disease and improving outcomes, given that it is the biggest killer of women. Women are heart of our homes, communities, families, and friendships, and an empowered and healthy woman can change the world. This is the slogan of the Royal Women's Organization here, and I think we all need to embrace this. There is today Red Feb for 2023, which is about wearing red and donating for heart research for women. In the US, they've had for many decades a campaign called Go Red, which literally talks about the fact that 1 in 3 women is dying from cardiovascular disease, but even one woman dying is too many women dying. Hence, we need to start thinking about going red. And it stands literally for G, for get your numbers, meaning your cholesterol, your blood pressure, encouraging patients to go and talk to the doctors about the risk factors, asking them to own their lifestyle, telling them to realize their risk, talk to their family about the risks, and then not to be silent, but to speak up to get better health care from their doctors. And so if there's any questions, I'm happy to answer them.
So, Anita, can you tell us a little bit more about the calcium score in women?
Sure, that's a really good question, Lydia. So calcium score is a very good risk stratification tool. So you use it where you want to decide if the patient is low risk, medium risk, or high risk. And I would use it in someone, say, for example, if they've got a strong family history of cardiovascular disease, they may themselves not be at having any other risk factors. So I need to know, do I need to be more aggressive? So I will do a calcium score. If it comes back as 0, I can reassure the patient that, look, you seem to be low risk for the next 5 years. It only is valid for 5 years, so we will need to revisit it in 5 years. But in 5 years' time, we'll look at it again. But at this point in time, you seem to be low risk. On the other hand, if someone's very averse to getting treatment, say for statins or anything that I think they should be to address the risk, I will then use a calcium score. And if it comes back as a high calcium score, say 100 and above, I would then be talking to this patient, look, you are actually moderate to high risk. And you should seriously consider disease modifying treatments to prevent an adverse outcome such as an MI or a stroke. So it helps me stratify people into which bundle they fall and helps me motivate patients if they are very ambivalent about treatment, which I think will be life-saving. Or on the other hand, if I feel a patient does not need a drug and I can just do aggressive lifestyle modifications and that'll suffice, I will use that calcium score. It is not Medicare rebatable. However, the cost is around $110 to $120. And if you put it in perspective for patients to say, look, it's a money that's well spent because it's giving you a lot of information about how to manage your risks or, telling us whether you are high risk or not. Therefore, it's worth spending that money. I think most reasonable patients will, take that test up and do it. And I think, as you said, Lydia, that you use an analogy of it's like less than what your wheel alignment costs for your car. I think once you put it in perspective to patients, far more likely to embrace it.
Thank you so much for your talk, Anita. Thank you for your clarity and highlighting this really important talk for our medical women in the month of February for this year. And we hope it'll be an ongoing conversation amongst our women. Thank you again.
Thank you, Lydia. You're most welcome. I enjoyed presenting the talk.